about what's going on with them, which is also really cool.
I'll be reminded of something. But, and you guys are in a unique position as well. Like, part of my story is that I was a people's client in the last part of my addiction and in the first part of my recovery. You know, shockingly, I didn't have any money. And I know from firsthand experience, like when I was in Los Angeles, if you're poor and you don't have any way to pay for medical treatment, it's brutal. I had cat scratch fever in 1990, and the only way to get at 102 fever for 4 months, and the only way to get medical treatment was to go to the emergency room at County General and sit for 6 or 7 hours to get 5 minutes with an intern who may or may not speak English. And it was brutal. And then I got back to Austin, and one of my friends told me about People's, and I came, and I actually saw the same doctor every time. And I saw the same nurses every time, and they knew my name. And so they were in a position to help me with things that I didn't even think to ask about. And that's not typical. I applaud you for that culture. But it also puts you in a unique position to be able to ask a difficult question and actually get a response from somebody, because they already trust you because of just who you are.
How did you feel different about that, about being anonymous in LA? Did you feel that human connection helped you to just bring something up when that moment arose?
Well, you know, getting sober wasn't a product of being part of the People's thing, but like I developed really severe uncontrolled asthma. Turned out I had developed a wheat intolerance. I didn't know that, so I was eating the pasta all day every day because I'm poor, and I couldn't breathe all the time. And I was coming in and I saw my doctor at People's, and they asked me if I had ever heard there was a brand new medicine called Advair. And they asked me if I would be interested in that, and they were getting me steroids to help. And it's like they were helping me treat this thing that I was just going to try to walk it off with my health plan. I'm poor, you know, rub some dirt on it, whatever, you know. And but they kept pointing out to me that that's not okay, you know. And so by being able to have somebody who is asking questions and offering help, giving me samples, getting me signed up with a drug company that would give me the drug because I couldn't afford the drug. You know, those were life-changing things. That all happened right after I got sober. But that was life-changing stuff, you know. And it wasn't that I didn't think I could get help. It didn't occur to me to ask because I'm poor and I'm just used to there being no options. You know, so having a relationship with somebody and them bringing up this thing that I didn't even come in to see them for made a huge shift in my life. You know, and that was crucial. You know. Had they not went, so what, you know, this is the 5th time I've given you a prednisone dose pack. How else might we deal with this? Because we're not controlling it. I don't know. And so one thing led to another, and eventually we discovered the wheat intolerance, and with the Advair, I've never suffered from asthma again. It's never been a problem in 20 years. You know, but that started with a conversation with a doctor here, so it was awesome.
Good question. I work predominantly with kids, and so I work with the parents, and usually in my first session with them, I ask a lot of questions, family history of like trauma and substance use, and I find that a lot of the parents minimize those experiences, like, you know, just, or they deny it or omit it, or,
Sure.
And so sometimes I wonder if having if you get like if you have like a screener and you ask about like, oh, I see that you're drinking 6 glasses of wine a day, right? Is bringing it up kind of like when you're assessing for suicide? Are they more likely to tell you if you bring it up, or do we still have some of that minimizing, downplaying? Do you know what I mean?
Yeah. So we're going to talk, I'll like partially answer your question now, but we have a whole section on like, so if someone tells you that they are drinking, what do you do, right? Like how to handle that. But like in short, I think probably everyone will minimize. You know, like you may even minimize if you're someone who occasionally has a glass of wine and you go to your doctor's office and they're like, how many glasses of wine do you have? And you're like, what sounds healthy?
What's the good
2? I have 1 glass of wine. You know what I mean? Like it's natural to be like, you know. So it's not about getting the exact right answer from them. It's about opening the door to have a conversation.
Okay.
And I think you said before, it's also like it's being a person who's asking, because depending on their environment, you may be the only person who's asking about it. So it's like using that relational foundation, right? So it's like you know you're coming from a place of care and wanting to help them, right? It's not like, and we'll talk, the screener we have does not say, how many drinks are you having a night? It says, has anyone gotten on your nerves because they're getting on your case about drinking, right? So it's like a different entry point to, that's a little easier to say yes to maybe than like, are you having more than 4 glasses of wine in the sitting? You know, it's like, everyone knows like they're effing up if that's, like, that's maybe not the easiest way to open the door. Yeah, but we'll talk more about that.
And also, especially your clients are going to want to minimize because they're afraid if they're honest, they'll be refused services.
Yeah.
You know, even though they've never been told that, I'm afraid if I admit anything like this because they still think it's a moral issue too. And so being able to approach it as just like every other health screening as a cultural thing about, okay, now we're checking on your asthma and we're checking on this and we're checking on this, and it just becomes part of what happens. It begins to allow them, and maybe even reinforcing that as we go, is like the answer to these questions in no way affect your ability to receive services. They may not be honest the first time, but because you continue to see them, they're going to trust you more and more with the truth. And that's a big piece of it, because they don't want to lose services.
Right. And also, and we'll talk more about this, but also it's like, I think for staff, why ask the question if you're like, well, great, now what do I do? Like, how do I get you help? And like, is there anyone that my patient can afford, right? Like, so it's like, why open the can of worms if you know you can't show up and be supportive? And then I think, like you said, if the default is like, oh, well, there's not going to be anything for me, right? Because I don't have like fancy insurance. The cool thing about Austin Recovery is our whole mission is like people deserve care even if they don't have the ability to pay. And so like a huge majority of our patients don't have insurance. Or are, you know, below the poverty line. And so letting them, as you ask the question, letting them know like there is also help, there's help at People's that you don't have to, you don't have to pay for it. And there's other ways to get connected to support that it's not, you know what I mean? Like there actually is help for you. I think sometimes also maybe changes whether or not someone is going to even tell you what's really going on with them.
And if you go in the family dynamic, you also might be afraid to admit something because you're afraid of your children being taken away from you.
Yes. And we have a whole section on that as well. Yep. So real quick in terms of, we know that y'all are already screening and have the lovely behavioral health team. And so you already screen for mental health. And we also know that you're seeing people with mental health and substance use because again, you're sending them to me. So we just want to do a quick overview of kind of what their research says about best practices because it can be complicated. And we also know that most systems of care are not necessarily resourced in the way to address everything, right? And that y'all are busting at the seams. So what we know is that people with co-occurring substance use and mental health disorders in general have poor outcomes, right? They have higher rates of relapse, of suicide, homelessness, incarceration, hospitalization, and just general quality of life. So if you've got the double whammy of like mental health challenge and substance use challenge, you're at higher risk, right? And of course, we also know that because we already talked about like the early things that kind of go into impacting substance use, it's not uncommon for people to be struggling with both depression and substance use, trauma and substance use. We'll talk more about that. So integrated treatment programs are more effective, right? I mean, and that's, it seems obvious, but it actually is like taking systems of care a while to catch up with that because, you know, it's complicated to cover all your bases. But basically, we also know that people who have to sort of navigate those systems separately, who have to like independently go into siloed systems, that they have poor outcomes.
Yeah, I was you know, I'm a dual diagnosis guy, you know, chronic depression my whole life, but in my addiction, I was getting treatment for my psych issues through MHMR and treatment for addiction in other places, and nobody ever talked to each other. And I know that it was impossible to get a legitimate psych diagnosis because of my substance use disorder. Was the way it was presenting was so confused. I was diagnosed with all kinds of stuff that wasn't true. Once, you know, I just hadn't mentioned I'd been up for a week at the intake appointment, you know. You know, but you can't deal, I would never have gotten sober had not a nurse at the methadone clinic I was at read an article saying that putting somebody on double the maximum recommended dosage of Prozac for a short period when they're in active addiction often had positive results because you couldn't get the drugs to a efficacious level in the bloodstream because the liver's working overtime to get the other street drugs out. And that was part of my story, is getting, and then once I got the heroin, methadone out of my system, the Prozac went down and everything evened out. But you have to be able to address both. You can't just try and stabilize the mental health issues and the substance use is going on, and you really can't just take people off of the street drugs that they're using and then start addressing. I mean, I think almost everybody in the first year probably needs to be on some sort of an antidepressant, just because dopamine levels are a mess. But whether that needs to continue on or not takes continued conversations with medical professionals. But they have to be dealt with simultaneously. And sadly, that's not really how the system is built largely. So
yeah, and what we know is that even though there's continued research that people have poor outcomes when the systems are separate, that even today that's more common than not that people have to go get desperate care, right, where they have to go to one or the other to get help. And there still kind of is that message like, well, you need to deal with your substance use before you can deal with your mental health. And you can understand where that comes from, because yeah, there's some pharmacological interventions that maybe you can't prescribe if someone is actively using, and the differential diagnosis, right? Like, what is actually going on with their mental health? Well, it's changing your brain and your mood is impacted by your use. So it's true that you can't necessarily like come up with exactly the right mental health diagnosis. That's not the goal of integrated treatment. What we know is that the more people have to like go to siloed systems on their own, the more they struggle, right? And also that it's really important to kind of get curious about how the substance is the best coping skill that they've managed to cobble together, right? Which is not like a great, do that for the rest of your life, but if we don't understand like how it's actually like a coping strategy that's no longer working, then we really can't get to the underlying stuff and we can't really shift things.
And that's one of the fundamental messages that hits the clients who come to inpatient treatment the hardest, and that doesn't get talked about much, is that in active addiction, drugs and alcohol are not the problem. They are an attempt to solve the problem. It's a solution that brings its own set of problems, and eventually it doesn't solve anything and it creates more problems than it fixes. But that's why just saying no if you're an addict doesn't work, because I can't stop pursuing drugs and alcohol as a solution without starting to pursue something else to fix the problem. Yeah.
Did you have to find some other form of meaning? Because there's no shortage of meaning when you need to use 3 times.
Oh yeah.
Did you find another source of meaning or focus?
12-step recovery is what did it for me, and discovering that the thing that was eating me alive from the inside was a spiritual issue at its core. I've got lots of trauma, I've got chronic depression, but I've also I was having panic attacks on heroin, which theoretically is impossible, but I was doing it. But the panic attacks went away in the first 90 days of sobriety working a 12-step program. Once I began to deal with the spiritual issue, the thing that I was dumping the drugs and alcohol on, my thinking got better, everything cleared up. For me, that was the thing that worked. It's like, oh, this is the problem I was trying to solve, the problem of just being Chris. The problem wasn't drugs and alcohol, it was being Chris. Going to the grocery store, I needed a level of narcotics in my system used on the battlefield for amputation in order to pay my cable bill, and that's not functional. But yeah, there has to be some other solution, whether it's 12-step or some other active program of recovery. There has to be an active program of recovery to replace, the thing that to fix the problem with the drugs and alcohol I was trying to fix with drugs and alcohol.
And I also think that's where, so like 12 steps is a huge pathway for that, and it's a pathway of like belonging in a different way, right? And I also think that's where behavioral health has a really unique role, that even if the person you're working with is in pre-contemplation or contemplation, right, and they're not, probably especially they can't conceptualize a world where they can manage what feels unmanageable to them without substances, right? They have no pathway for hope. That's where helping them understand like what's underneath that, right? It's not just that you want to do heroin all day wrong, right? Like that started somewhere else, right? And recognizing that and validating that, and also building the pathway that like, yeah, there actually may be some other ways to survive that, right? Like you can survive your anxiety without having to drink 5 drinks before you leave your house, right? They're not going to have a lived experience with that being possible, but you can help them kind of figure out what is the thing that feels unmanageable, and like plant the seed of hope that there are other ways to manage that. And that's, also especially true with like the intersection of substance use and trauma, right? That we know that a huge percentage of people who are struggling with substance use disorders are also struggling with trauma, right? And that it is a coping strategy. And so to ask someone to survive that without giving them the supports, right, or like building the pathway is sort of, I mean, that doesn't sound like a very good deal to me, right? You want me to just stop doing the thing that helps me wake up in the morning, but like be alone with like the horror? It's not very motivating.
Well, and also we have to be cognizant, you know, when we're looking at trauma, that it's not all capital T trauma. Like when I say trauma, our brains go to things like violence or rape or something like that. You know, I for years said, I don't have any trauma, nothing like that ever happened to me. But there's small T trauma too, and that matters. You know, I've seen people die. I've found people dead in my house. You know, it's like, but I didn't, that's just the life. You know, people die doing what I'm doing. And I just kept on going. But apparently, you know, my therapist disagrees on whether that's trauma, you know. And so sometimes it's a lot of small T trauma that's driving this, and not some big giant event-based thing. And so that's something we have to watch for and help them identify as well. Because it took me 15 years to recognize, 15 years of happy, successful sobriety to recognize that there was other stuff I needed to look at. Because I just told myself it was no big deal. You know, which is also quite frequently what people with childhood abuse and other stuff tell themselves, so it's not really that different. So.
Right, if you have no context for having a different experience, how are you supposed to know that your difficult experience isn't what everyone goes through, or that has some lasting impacts? If your job is to survive, then you've survived, right? And that's the first, most important thing, is to survive. But then after that, you actually deserve to get to have like some thriving and life experience, right? But sometimes we need help kind of getting there. So this is just my favorite little image that describes that. So it's like the person is not asked to give up the old pattern, which he cannot do before he has another substitute. So that's where I feel like the framework, especially here, and especially on the behavioral health side, where it's not your job, like your intervention is not getting someone to stop. It's like figuring out, why does it feel impossible to stop, and what are the things you might need. And some of that is treatment, right? But some of that is other behavioral health stuff, self-regulation, right? The ability to tolerate yourself. If you feel disgusting, right? Who wants to be alone with that? And so there's important, like, kind of like building the pathway for hope can happen before, when someone's in the early stages of change. Okay, so speaking of family treatment and pregnant and parenting patients struggling with substance use, we know obviously we're going to be at a Center for Women's Health next week, but we know that's something that y'all have been dedicated to for a long time, right, is providing support to parents. And what we were talking about before, so obviously we know that maternal substance use has really increased risks, of course, for the baby in terms of like prematurity, low birth weight, neonatal abstinence syndrome, but also for moms, right? If they're using substances while they're pregnant, there's higher risk of developing depression. And then also, even if you're able to be abstinent during the pregnancy period, there's also higher risks of relapse in the postpartum period, right? So it's just, so this is something we know, it's scary. It's scary for everyone. But what's also true is that there's women in particular face increased barriers to getting the help that they need, right? Because first of all, like stigma and fear of CPS involvement, so like you're not going to tell anyone, right? Because you don't want your child to be taken away from you. And then also, let's say you did want to go to treatment. What are you supposed to do if you're the primary caregiver for your child, right? So like historically, women get a lot less treatment than men because of these factors. And so we're going to talk a little bit about the research, which is, you're going to kind of notice a theme here around the idea of like integrating services. So it turns out if you give people multiple things that they need in one place, they do better. Which again, like the same thing is true with like integrated health. It doesn't really seem like that big of an epiphany, right? And yet it's still not common. So we're still kind of catching up in the healthcare fields. But what we know is that if you can integrate treatment, if you can give someone services for pregnancy, parenting support for their children, in combination with addiction services, that they do better, right? Which, duh. And they have better outcomes too, better like immediate health outcomes and better long-term outcomes. And so, and some of those outcomes are in terms of, parenting skills. So this is like the preventative health right here. So we talked about the ACE study before, how our experiences early in life impact us. This is one way to directly confront that, right? Supporting parents to get their needs met, to be healthy and safe so that they can be healthy and safe for their kids. That's like preventative health work right there. So, and of course, if you can support, so getting parenting support helps in the short term, but also helps in the long term for moms and for kids. And then, of course, if you can support the mom in being safe so that she can continue breastfeeding, it's sort of like tapping into one of our like biological preventative factors, right? That like there's really cool research, especially in some of the methadone clinics, that like babies born with neonatal abstinence syndrome who are able to breastfeed like spend shorter times in the NICU and do better. So it's not just about like getting the kid out of there and getting them health, right? That if you can help the mom, the kids do better as well. Yes.
So in Texas,
Yeah.
they have linked high rates of maternal mortality to opioid use. So here we have a pediatric department. So, you know, the newborn babies are coming to our clinic. The mom may or may not have, you know, a substance use issue. How, like, in what context is that opioid being prescribed, and how should we look for that?
Yeah, like look for risk factors.
Yeah.
Yeah. So this is also where like the screening can come in terms of figuring, the earlier you catch it, the more you can connect them to support. So, I mean, a lot of, I know you just went to a really cool conference on this, Dwayne. I don't know if you want to speak to some of the treatment that you're seeing, but like, you know, keeping moms on Suboxone or on like MAT treatment so that their rates are monitored so that it's like not having a spike while they're pregnant is safer for the baby, right? Instead of like them like withdrawing, and then even afterwards to keep them on like a safe dose is where. So in this research where the babies are breastfeeding and their symptoms are going down, the moms are still taking like a methadone-assisted therapy.
The big thing with that is that mothers rolling over on babies and smothering them at night is actually a big deal. And that's the whole back to sleep thing. But it's not every mother. Most mothers aren't that way, but mothers who are smoking, alcohol, sleep apnea, obese have higher risks of that. So I think part of it is understanding what the point of injury is often. I mean,
Well, and also, the highest rate of opioid overdose and death happens in people after a small period of abstinence. And oftentimes, when people are pregnant, they will manage to stop using. And but the minute they go back, it's often the first dose. Like somebody gets out of rehab and they relapse and they overdose and die because their system is completely clean, they have no tolerance anymore. And you know, we talk about the social stigma around addiction, and with mothers it's 10 times as bad as anybody else. And you've got this like, how could they do that? You know, and for me, I believe we evolved as a species to be unselfish around small children for the survival of the species. But as an addict, my disease forces me to be self-centered all the time. Fixing what's wrong with me is always number one on my to-do list. And that's part of why addicts are so uncomfortable around children, and it's part of why moms will do things that are just inexplicable, even to themselves, towards this child that they want to love with all their heart, but their addiction is forcing them to think about themselves first. And so they want to take care of their kids and getting them onto some stabilizing. We're working a lot against stigma in the abstinence-based 12-step world around MAT therapy because it's the best approach for some people. Once again, we don't have a diagnostic tool for who needs to be on long-term medically assisted treatment, who just needs it for a period of transition. But we don't ever take pregnant women off of methadone when the child is born, and we don't encourage them to get off during the first year, or to gradually detox over the course of the first year, so that they can begin to work an active program of recovery, so that as the drugs come out of their system, they build other coping tools.
Yeah, and I think you know, us recovering, we used to detox pregnant women off of opioids. We no longer do that, just because it's such a dangerous thing. But what the research is suggesting is that we had a mother recently who gave birth to an opioid addicted baby, and she would take her methadone dose, go to the hospital, breastfeed on a daily basis. Baby was in the NICU, you know, maybe 3, 4, 5, 6 weeks, something like that. what the research is suggesting that is if you put the baby with the mom, let the baby be with the mom as much as possible, skin-to-skin contact, out of the NICU, that this actually has better rates of the baby, I guess, not needing as much care or less amount of care.
Shorter stay
in the NICU. And,
Rather than detoxing the baby right out of the gate.
correct.
Kelly, Drew?
Are we going to talk a little bit later about MAT and Suboxone treatment in a primary care setting? Are you guys going to bring that up at all?
That sounds like the topic for another training.
All right.
But we can like field some questions about that.
Okay.
Yeah. In terms of like what to do and if it's a good idea or.
Yeah.
Yeah.
Just in general.
Yeah. Yeah. We can visit that. Yeah. So the other reason why we bring this up, of course, we want to show where the research is in terms of it's better to have an integrated approach to support, but we also want to make sure that y'all know that another cool thing about Austin Recovery is that we have a family house program, and so moms, actually parents, so it doesn't have to just be a mom. If a dad is the primary caregiver, he also, with young children, can enter treatment and take his kids with them. And that is also regardless of your ability to pay. So of course, depending on like wait lists and the funding streams, there can be a wait list, but that we have one of the only nonprofit family house programs where you can go to treatment if you're pregnant or parenting, you're struggling with substance use and you need to take your kid with you, or people give birth like in treatment sometimes. Yeah, and it's a minimum 90-day program, and they get legal help, they get parenting support, they get substance use support, they get connection to their primary care needs, so all their like follow-up medical care.
We interact with CPS and drug court a lot. A lot of them come to us by way of CPS and drug court. So, we're integrated with those programs, and it's a good deal. A lot of these
Yeah.
women would not find help otherwise, so.
It's important for all of our clients, really. I mean, if you think about like, you are familiar with Maslow and his hierarchy of needs, but right above physiological needs are the safety needs. And if you don't take care of those safety needs, once they get out of treatment, they're pretty much falling into the same cycle. They don't feel safe, so they use, right? So we help them kind of feel safe by helping them navigate the legal system, navigate the CPS system, find housing for themselves, get them set up with whatever resources they need, WIC, whatever they need, we try to help them. And so for the moms, it's a minimum 90-day stay, whereas for everyone else, it's a 30-day to 90-day stay.
Yeah, and it's actually like a proactive approach to CPS. So it's instead of like being like kind of living in a place of being like afraid that you're going to lose your kid, it's more like, right, the goal of this is to be able to stay with your child, right? So and then CPS is like part of the family drug treatment court program. So it's like everyone is an active participant in making sure that the mom has resources so that she can like continue to parent her child, if that makes sense, versus like trying to catch you doing something wrong. It's like, yeah, we know you're struggling. Sounds like maybe you need some support. And that's all stuff that they can get in our family house program. So we just like to share that because I think that's one of the coolest kind of things that we're doing in terms of access to getting care. So any other questions?
It's awesome that you guys do that because I didn't know. So now.
Yes. Little known fact, yeah, it happens in Buda, so that's where our residential treatment facility is. Okay, so now we're like getting to the meat. You're like, okay, this is good information, thank you. Maybe some of you have already heard some of this. What the heck does it mean for you in your daily workflow at People's, right? And again, what we kind of want to do is instead of this being like, oh my gosh, this is like another thing that I have to do, and I don't have time for this, or like, what am I supposed to say? We really want to like set you up to see where already y'all are doing important work and you have a room to have an impact, right? So, in terms of universal screening, the good news is that the Cage 8 is already available in NextGen. So that is the screening tool that we were talking about that's a little bit more like, it's not as sort of judgmental in terms of trying to kind of identify risk factors. So we're going to talk a little bit about the Cage 8, and then we're going to talk about kind of how to introduce it and like what to do if someone actually screens positive on it, how to actually have an effective conversation with them about their substance use. So this is an example of the Cage 8. Excuse me. But what I like about it is these questions are like, oh, that's like, I can maybe say yes to that, right? Have you ever felt like you should cut down on your drinking or drug use? Have people annoyed you by criticizing you for your use, right? Have you ever felt bad or guilty about that? And then have you ever had a drink or use drugs first thing in the morning to kind of steady your nerves, right? And we're gonna come back to this, but what's good about this is that if people say yes to this, they're already giving you information to start the conversation with, right? So instead of saying, did you know you're not supposed to have more than 4 drinks in a sitting, right? You can say, wow, it sounds like people are really getting on your case. Like, that must be frustrating. So just the screener itself gives you like a pathway to the thing that they're already willing to acknowledge they're struggling with. Does that make sense? So it's kind of like it's like a cheat code. It just tells you where the doorway is. And of course, for y'all, we also know that sometimes your patients are already doing it. You don't need a screener, right? They're just telling you anyway. And so it's the same idea. It's like the thing that they are willing to acknowledge to you is the entry point. Because it's the thing that they're already having some awareness of that they're struggling with, and when they verbalize it to you, like that's the thing to just reflect. Like you don't even really need to do much other than just let them know that you're hearing the thing that they're acknowledging. So we'll talk more about that in a minute.
Yeah. Jessica pointed out that if you answer yes to one of those, it's a positive screen.
Thank you. Yeah, so just one yes is a positive screen. So that's sort of like if we're looking at the SBIRT model in terms of screening, brief intervention, referral to treatment. One yes on those questions means have a conversation, right? Have a little follow-up. And then, if they're willing, connect them to treatment. So, this is the phase of like, okay, they said yes, now what do you do? We wanted to highlight this, and we kind of already touched on this earlier, but one of the things that I love the most about partnering with Peoples is that you already are doing some of the most important things to set yourself up to have these difficult conversations, right? Like inherent in your values are being mutually respectful, caring, patient-centered, right? And so just the values that you already bring every day to work into how you interact with the people that are here and that relationship, right? You're talking about kind of the relational foundation. That sets you up to be more effective in having these difficult conversations. So, good job.
If I could add on that,
Yeah.
that I speak to people in terms of helping them be free, helping them achieve freedom so that I'm not coming down in any way, but I'm showing that I'm an ally and an advocate by speaking in terms of helping them with freedom.
Right. Yeah, again, it's like, I think what we know from the research is that telling someone not to do something is not very effective, right? In fact, it's probably effective in perhaps getting them to be more likely to do the thing you want them not to do, right? If we argue one side of the argument for people, if we're like, this is why you need to not do this, what we're leaving them with is the other side of the argument, right? And if someone is kind of on the fence about whether or not to do something, you don't want to argue the wrong side of the fence, right? And so it's not about, again, telling people to stop doing what they're doing, because the research is pretty clear that that's not effective, right? But it is about creating that pathway of hope, about acknowledging what they're already telling you, right? Like they're already giving you the information you need, and then kind of building the pathway to hope that there's a place that you can get help, right?
Yeah, I mean, if I'm telling you what not to do, you immediately have something to push back on.
Right.
You know, I got kids, I know all about that. But if I can present you with options, other options for solving the same problem, there's not as much to push back on them. And we can have a conversation about why your option may work better than mine, but at least it's a conversation. And eventually, some people get